we are going to start our instruction course. That is, I will never forget my longest days in VR. So these are our eminent speakers. Myself, Dr. Devdulan Chakraborty, is the head of the Department Retina in Sharadapalli branch of Disha Eye Hospital. Dr. Aniruddha Maiti is the HOD Retina in Sushrut Eye Hospital. Dr. Shantanu Mondol is the senior VR consultant in Disha Eye Hospital. Dr. Aditya Kelkar, the director of NIO, National Institute of Ophthalmology, Pune, and Dr. Dharmesh Kaur. So we from Mumbai. So we are going to start our session with Dr. Aniruddha Maiti. So I'm handing over my talk to Dr. Maiti. Please, Dr. Maiti, share your experience regarding the longest days.
Thank you, Dr. Boral, for giving me this opportunity. Well, I will be sharing few of my longest days in OR, or few of them were nightmares too. So without much delay, we'll start the videos. So these are the 4 cases which I'm going to show: dislocated IOL, spontaneous retinotomies, lost flap, difficult macular hole. To start with the first one, this was a simple case of a dropped IOL. As we can see, one of the haptic being stuck. So doing the vitrectomy and getting it disengaged and clearing the vitreous around the IOL. Then with the cutter itself, we are hanging the IOL and then taking out the IOL. Making the main port. And then try to retrieve the IOL. Till this phase, everything was fine. And then something happened. The IOL was stuck somewhere. And then I realized that the haptic got badly stuck to the iris, and from the iris, the profuse bleeding started, both anteriorly and posteriorly. As you can see in the video, there's a profuse bleeding underneath as well. There was a loss of glow, and the bleeding was very difficult to control, and iris was badly stuck by the haptic. Haptic was stuck in the iris. So tried to put some visco, control the anterior segment bleeding, and trying to manipulate the IOL so that the stuck haptic gets dislodged. And by flipping it from the other side, we could manage to disengage. But this was a quite long process, not like what has been showed in the video. So there was a lot of adrenaline flow that time. Well, you can see the posterior segment is full of blood, clearing the blood. After clearing the blood, we put an iris claw, because by that time there was no iris bleeding and iris was quite healthy. So we put the iris claw. So the simple case, there was definitely a code red situation, which we managed, and the patient got 6/9 vision as well. This is the second case, comparatively an old RD, not very old as the look says. After doing the PVD induction and meticulous-based dissection, we made a retinotomy in the nasal side, and we can see the thick fluid coming out. Along with it, a surprising thing happened. You can see the retina got splitted. There was tension retinotomies all over the retina. In all quadrants of the retina got splitted. This was a very unusual finding, which I never saw in my career. In last 15 years, I've never experienced such a situation that retina gets splitting everywhere. And actually, with the tension retinotomies, the retina settled well. You can see the multiple breaks in the superior part. And then we had to do a laser. in all the retinotomies, tension retinotomies. Might be this was due to an atrophic and old retina detachment, and putting in buckle might have prevented. The third case, this was a macular hole. It started as a simple macular hole, and while peeling, I realized this macular hole is quite large, and conventional peeling might not work. So that time it was quite, it was late to plan an inverse peel because I have already peeled around the island, around the macular hole. So what I thought, I will put an free flap. I'll do a free flap technique for this macular hole. So try to stuff in the ILM inside the macular hole. Although the ILM was quite large enough, so I thought I will trim it. For the time being, let me put it inside the macular hole. Then later on, I will trim it. But as there was no planning, actually, I had put two valve cannulas and another one was non-valve. So as I removed the instrument, there was a loss of it. So obviously, it took a very long time to ultimately repose the flap under PFCL. So a proper planning before the surgery is very important. We could prevent the loss of flap by putting some PFCL and placing the ILM under PFCL, using valve cannulas only, or using a chandelier and stabilizing the ILM with a forceps and keeping the infusion pressure low. And this was another case, which is my last case. This was a very high myopic presented to the macular hole, comparatively simple case. But the problem is that no instrument was actually reaching the ILM level. You can see with the finesse, I thought I will raise a flap and then I will peel with the ILM peeling forceps. But after numerous tries, removing the cannula, placing the cannula more horizontally also, nothing actually helped. Ultimately, I had to proceed with the finesse loop. In the total ILM peeling was done through the finesse loop, which actually I don't use in any cases. But here, actually, this was the instrument which saved the uh, actually helped in managing this macular hole in a high myopic patient. And you can see we are peeling the ILM with a finesse loop. Sorry for the video because it was so high myopic when I was pressing, it was getting defocused. So however, managed to do the ILM peeling and ultimately the hole was closed through some unconventional method. So the take home message, any complication irrespective of nature and extent can be resolved through patience and definitely timely management. So thank you for patient hearing.
Thank you, Dr. Maiti, for these nice, interesting cases. Like the purpose of our this IC instructional course is to discuss the common hurdles in apparently looking predictable cases where you have stuck up cases where you have just marginally escaped after managing. Somehow you have managed with some innovative manner or with some unusual way. So, in your first case, can I ask one question? Like, why there was the haptic has been engaged in the IDs and the bleeding started?
Yeah, generally this doesn't happen. This has happened only once in my life, at least in the last 15 years. What I feel the iris in this kind of cases, the IOL should be guided. If the light pipe can help it, keeping the light pipe instead of pulling the with the IOL with the MacPherson forceps, the endolight can actually help in guiding it. And if I support it with the endolight, then this kind of complication might not happen. Although rare, but once in a while we can land up into this problem.
In your macular hole cases, it was looking quite large from the very beginning. As you are told, because proper planning was not done.
It was a lack of planning because otherwise we have done an inverse pill technique for this.
Yes, otherwise you can start doing the planning accordingly. So you can use the PFCL also. Thank you for your sharing the experience and that intrinsic retinal contraction. What you have shown the multiple tear happen in the periphery. That was very interesting. Most interesting. I have seen it a lot of times, but for any people, any student or any undergraduate or postgraduate student, this might help because they should take their mind in their mind that retinal contraction can happen without any visible.
Vitreous cavity, or whether it was subretinal, but actually I couldn't manage to see because of the poor visibility, because of the vitreous hemorrhage. So I thought I'll proceed with the other sclerotomies. So again, it was a soft eye, and finally managed to twist and turn, and when I removed the trocar, huge gush of fluid that came out, probably again from the choroidal detachment. And then I put in my cutter, and I was happy to see the cutter inside, behind the lens. So I thought, okay, so I'm in the vitreous cavity, but actually the nightmare had just begun. So I took up the endo illuminator and I put it inside, and I was, I felt really scared. I had, no idea about where I was, whether the endo illuminator was in the vitreous cavity or subretinal, whether there was, vitreous hemorrhage with detachment here also. And I almost thought, "Bhai, kahan phas gaya main?" And what to do? Do I, proceed with the vitrectomy, or so in these a little time was spent, and I thought, okay, enough was enough. And so I thought the first thing that I need to do is clear up the lens. So we did a lensectomy at that point in time, and initially with the cutter, and then some of the chunks actually could not be removed with the cutter, so I enlarged with a 20 gauge MVR, and put in a fragmatome, and took a fragmatome to actually remove the other pieces. But thankfully, the view became much clearer, and I could see the retina in this part at least. And after removing the lens particles or pieces, I could see that there was retinal detachment inferiorly and nasally. And so then I knew, okay, the retina is there, and I could chop off and cut off the vitreous and the vitreous hemorrhage little by little. So started clearing up the peripheral vitreous and the vitreous hemorrhage. And then after a while, I used some triamcinolone acetonide to ensure that there wasn't any vitreous left behind, and then proceeded with base excision, quadrant by quadrant. So this actually was followed by retinotomy for draining the subretinal fluid. I didn't use any PFCL in this case for settling the retina. So the retina settled well, in fact, and with fluid air exchange, we could settle the retina. And then, of course, did endo laser, which was done 360-degree, and didn't have a problem with the endo laser. And this is how the retina looked actually finally. And of course, we put in silicone oil. The endozyridectomy was done as it was a phakic, and finally closed the case. And actually, the patient did well. And to my surprise, actually, patient had 636 vision in the 3 weeks post-op. So that's the first case. The second case, this is a 73-year-old lady, mother of a physician, and uncontrolled hypertensive, and PLPR. The ultrasound looked pretty routine, except for something here, looked like a mass to me, actually, and wasn't really picked up well on the ultrasound. So we started off with the vitrectomy, which seemed, sorry for that, I will share my screen again. Uh, just a moment, there's a glitch, I don't know. I'll just share my screen again. Okay, so here it is. So we'll straight away move to the case. And here actually, so it was a routine kind of a vitrectomy to start with initially. And but when I started clearing up the vitreous, actually, something struck me. There was this area with this lesion here with some pigmentation and some retinal hemorrhage. So once the blood cleared up, I could see a mushroom shaped lesion with some pigmentation, and I started sweating, thinking that this could be a melanoma. And really started wondering what to do, whether to close the case or do some laser, or what should I do. So finally, after much thinking, actually I started doing laser initially, surrounding the the lesion, around the lesion where the hemorrhage I could see. And then finally I gathered up enough courage to actually do laser on the lesion also. So here, the peripheral area as well as the posterior pole, there was no detachment as such, no exudative detachment. So that was a good sign. So I thought this could be a hemorrhage or a kind of macroaneurysm. The lesion started blanching as I applied the laser, and little by little, actually, I carried on with the laser, and finally, what we did was we just closed with fluid air exchange. We didn't use any long-acting gas or even SF6, and actually, patient presented after 4 days, and at that point in time had developed a recurrent vitreous hemorrhage. So I was, still kind of scared, and did an ultrasound. The lesion was still there, and next I asked the patient to come back, but after in a week's time, but she couldn't come back because of the lockdown now. So after a long wait and 42 days of surgery, she came back, and thankfully the lesion had regressed a lot, and there was 6/9 part vision, and I could say that all's well that ends well. Thank you for your kind attention.
Thank you, Dr. Devural, for your nice and very interesting cases. First case, I think it was quite predictable, and just see the purpose of us, this IC was even the predictable cases can face a lot of hurdles due to like some unknown reasons. And in your case, what was the reason do you think the vitreous hemorrhage is not getting? There was any continuous bleeding what was happening inside, like from the scleral ports, or like for what for which we have to do the you had to do the lensectomy to clear up your media?
Actually, this patient was a blunt trauma patient, had been hit on the eye. So it was a soft eye, and there was some amount of hyphema that was there in the anterior chamber, and some amount of cataract. This unlikely to be a traumatic cataract. I thought we could manage with this kind of a cataract. The vitreous hemorrhage could be managed, and as the ultrasound showed only a inferior kind of a RD, so I thought I'll be able to manage. But once I was inside, I saw that it was difficult. Probably it was for bleeding mostly from the anterior part of the eye, from the ciliary body region most probably, and that is what it looked like when I started actually doing the vitrectomy. Once I kind of cut away the anterior and the mid vitreous and the vitreous hemorrhage, the posterior part was relatively easy, and even the PVD induction wasn't difficult. So after the lensectomy, the view improved, and we could actually manage the case quite easily.
And your second case, the mass was quite very much to the close to the vascular arcade. So
Yes.
that could be the macular.
Absolutely.
And maybe the recurrence of bleed after the surgery, after the rupture of the macular zone, that usually doesn't happen. This is a very unusual case. That thank you for sharing your these are very interesting and unusual happenings that happened in your case. So now I invite, I'm going to our next speaker, Dr. Aditya Kelkar. Dr. Kelkar, please.
Good afternoon, everyone. Thank you for inviting me into this instruction course. I would like to share my screen. I hope you are sharing the screen. Is the screen visible, the green color?
Yes, yes.
So I'm talking about the longest scleral fixation intraocular lens. So this is what happened when I was operating on a piece of Yamanese scleral fixated IOL was planned in this case. This is a patient who has had a radial keratotomy in the past, and there was a whole bag complex dislocation. So the standard technique of lifting the intraocular lens out using PFCL as a guard against any intraocular lens falling back again onto the posterior pole. And as you can see, the whole bag was dislocated. and this was pulled out using the suction of the cutter, and it was brought to the pupillary plane, and then using the haptic, using the dialer, this lens was brought into the anterior chamber. So after that, the remaining vitrectomy was completed, and then we decided to put implant the Yamanese scleral fixated IOL. This is a patient who's a very high myope, so the lens was also very bulky. So we started the standard way of using a 27 gauge needle on the nasal side of this patient and engage the trailing, the first haptic. After that, another needle is introduced on the temporal side, and through the main port, the McPherson's forceps will guide this haptic into the lumen of the needle. And probably I engaged this haptic little too much inside this needle. So when I started pulling off this haptic onto the temporal side, as you can see, the nasal haptic probably slipped away. So I kept on holding on to the temporal haptic, and there is a lot of bleeding here and subconjunctival hemorrhage. So obviously going through this area again will be more difficult, and in case the haptic slips, I will be in trouble again. So I first retrieved the haptic and put it onto the anterior chamber. I mean, put it onto the iris, so that the lens is at least well secured first. And then we can always go back and tuck the haptic again into the needle, ensuring that not too much of haptic is drawn inside the needle. And then the procedure is completed. The same thing you can do in case you are in doubt that the conjunctival visibility is poor. You can always use a trocar and cannula also for the same situation. So this is a small take-home tip, I would say, in case the haptic slips intraoperatively during the learning curve. These things are very common to have, and it's nothing like you should get very scared about. And you can obviously overcome this situation with this technique. Thank you. Any questions, please?
Dr. Kelkar,
Yes, please go ahead.
thank you for presenting on this interesting case. Now, I want to ask you, discuss what are the, like, it was an endocapsular dislocation, like whole IOL and the capsular bag was inside the vitreous cavity. So what are the other ways of removing this kind of IOL capsular bag?
If it was a 3-piece intraocular lens, I would probably remove the bag complex inside the vitreous cavity itself using a cutter, and you can implant the same lens back.
Yes, or
that's an option.
That is an option, and or any other method of removing this kind of.
In fact, I am quite. I've seen your videos also on scleral fixation. I find your way of doing a scleral fixation a little bit better than Yamanese scleral fixation. For a reason, I will tell you that this Yamanese scleral fixation IOL holds on to the sclera only at 2 points where the haptic is flanged.
Yes.
So I think the tunnel into the sclera is very shallow. So there's always a risk of intraocular lens tilt as the days advance, maybe 6 months or 1 year down the line, the lenses do once in a while. Whereas in your technique, I've seen that the haptics are engaged into the scleral pocket. So that makes the intraocular lens more sturdy and less chances of tilt in the long term.
Okay, thank you. And one more question, whether when to reintroduce your like your needle through the sclera, have
Yes.
you gone through the same port or you have
No, I
selected
make
the
a new
other
port. Yes, this is a good question. I go through the new port because always if you use the same port, there's a risk of enlarging that port and the lens may slip again.
Okay.
So it's a good idea to use a new port. A new
So any other question, any more questions to Dr. Kelkar from other speakers? So, so now I am inviting Dr. Dharmesh Kaur. Thank you, Dr. Kelkar.
Thank you, Dr. Boyle. Thank you.
Please be with us so that we can discuss it in our
Yes,
like
I am around.
yes, at the end. Yes. Dr. Dharmesh Kaur, our next presenter.
Yeah, just a minute. I'll just share the screen and yeah. Hello everyone. Good afternoon, Dr. Subhendu, for inviting me to this instruction course. And it's visible now, audible?
Yes, it is visible.
Yeah.
And audible also.
So financial disclosure is a none. And this is the case, a simple case which was referred to us as a drop nucleus for vitrectomy and secondary IL insertions, very common referral on indirect cortical material. Vitreous haze was there, view was not clear, and we have not anticipated anything great in this. Now, as we go through the video, so the nucleus, we can see the matter which is floating. We have gone with standard pars plana. The fourth port was for the chandelier illumination. As we enter inside, we saw there is a retinal detachment associated. We put PFCL, started eating up pieces with the help of cutter itself. We remove the PFCL. There was an epiretinal membrane, so it was stained. And what we see, there is a nucleus matter gone subretinal. So we did a ILM peeling. We have removed the matters, and then there is a made a scleral pockets, and secondary IOL lens was inserted in the scleral pockets. We went inside again after the IOL insertion. Break was barrage, and this is the post-op. So this is the sometime become a long day, and thank you for it. But some simple cases can be turned out to be a quite longer case. Yeah, thank you, Dr. Subhendra. Any questions?
Thank you, Dr. Dharmesh, for for showcasing this very interesting case. So, what do you think? What was the it was a case of macular hole with epiretinal membrane with retinal detachment with drop nucleus, subluxated lens.
It was not macular hole. There was epiretinal membrane, and there was a retinal detachment. So we were not anticipating. We thought it's just a simple nucleus drop. And when we enter, because of the haze and the nucleus floating matters, we couldn't see it. We enter, there was a detachment, then a membrane peeling, then subretinal nucleus matter we have to remove. So,
how we have removed the subretinal nuclear lens matter?
We have just put the PFCL and we have made a retinotomy close to it. And then we have...
That part is not shown in the video.
That the break which was laser. So at the end, the laser break was there. No?
Now, how we have removed the that lens particle from the break, that you have not...
Yeah, we have used with the flute tip needle. So we have used the extrusion silicone tip needle, went into the subretinal area and removed the pieces.
Have you used PFCL again at the time?
Yeah, okay. For the nucleus matter removal again, and for even RD2 for retinal detachment, we have used PFC.
Okay, Dr. Devdulal, Dr. Shantanu, any question for Dr. Dharmesh?
Yeah, nice and interesting case. Actually, a couple of thoughts that I had.
Yes.
Do you think while you were actually removing the nucleus or the lens, it was then when it went subretinal. Why I ask this question is, like I thought I saw you using valve cannulas, if I remember right. So with valve cannulas, I don't think this would have happened in while you were doing it, but probably during the cataract surgery, there was a little bit of fishing that was done, and that probably
Yeah, what I feel is this: they might have gone with the phacoprobe in the vitreous cavity or anterior vitreous cortex, and that would have caused the retinal breaks and retinal detachment. And that time, some matter had gone subretinally.
But you have not used the phacoprobe, you have used the cutter.
No. During the primary surgery, during the cataract, they might have.
Okay.
There was a drop. No, they might have gone with the phacoprobe in the vitreous cavity, which has caused the retinal detachment, and that time some matter have gone subretinally. Because when we enter and so there was already some cortical material and some nuclear piece was there in subretinal area.
Have you done the ultrasonography preoperatively?
No. It was referred in the emergency, and we just took it, did indirect, and we took it for the OR. We thought to be a normal case of drop nucleus with secondary IR, but turned out to be quite long.
Yes. Dr. Kelkar? Dr. Shantanu?
No, it's all right. Fantastic case. Fantastic case.
So thank you, Dr. Dharmesh, for showcasing your very interesting and nice and very these cases are nice to be experienced, and it is like if we are are aware of this kind of situation, kind of further cases can be further happenings can be stopped by using anticipating everything. So now coming to the Dr. Shantanu Mondol. Dr. Shantanu Mondol, please.
Am I visible and audible?
Yeah. You are visible and also audible.
Thank you. Good afternoon. Thank you, Dr. Boral, for giving me this opportunity. My topic is my longest veer surgery, longest day due to masquerading sign. So there are two parts in this topic. My longest veer surgery, I'm showing one case, and longest day due to masquerading sign. I should say pseudo masquerading sign. I'm going to tell that. So the first case, it's a simple case of post-pseudophakic RD. I've started with an intention to finish it by 30-40 minutes. But one thing I came to know in 10 years of VR surgery, that nothing is simple in VR surgery. Even in plain and simple case can turn out to be like this. See, there is choroidal detachment started, and why? There is regression of the infusion cannula. This is suprachoroidal cannula. So the choroidal started. I swiftly came out from the port and just changed the infusion cannula. See how it is regress. The color changes. So without taking a second thought, I changed it, the normal cannula, normal 23 gauge cannula with a 6 mm cannula, which is available that time, and checked the infusion tip and started again doing vitrectomy. Going a little bit slow because one problem happened. Might be there is another problem, but I don't know what is there in my hand. So the vitrectomy, slowly I have started, and PFCL given. I asked my assistant to decrease the pressure, and he suddenly decreased the pressure to 0. So this will create a negative suction inside the infusion port, and that will create this large iatrogenic break. So this is the second thing. I don't know how many still there. So see, a large piece of retina, torn retina came out. I slowly cauterized the edge of the iatrogenic break and started vitrectomy again. Oh my God, what are those things? Multiple torn retina came out, multiple torn retina. So it's a nightmare to me. This is the longest surgery, retina surgery I have done in my career, small career, but still it's a nightmare to every VR surgeon. So many complications in a single case. So I then started doing base excision slowly, more slowly. And once the base excision completed, fluid gas exchange started. Still, I am doing the residual vitreous cleaning. Now, basic fluid gas exchange started. Retina is now settled. Now, retina is settled. And the residual part is same in all cases. Want to dry up everything which is present, every bit of fluid present subretinally. Now I'm starting laser 360-degree barrage along with the barrage around the tear, primary tear and the secondary tears. Completed the laser. PFCL was taken out and silicone oil given. So it's a 30-40 minute surgery, turned out to be a 2 hours. So this is the post of 20/60 vision, but that is a nightmare. More adrenaline loss. This is my first case. And the second case is longest day due to masquerading sign. I should say pseudo masquerading sign because this patient around 65 years age with myelodysplastic syndrome had a history of platelet transfusion 3 times previously in the last 1 year. He had completed 3 cycles of chemotherapy and came with a vision of right eye 6/6, left eye 6/18, ERM with cataract. So I asked to go for cataract, but before that, everything, every lab test, whatever possible, I did that, and that is completed 2 weeks back. And patient took a date for after 2 weeks after completion of the test. So this is the case, cataract with ERM removal. So it's a simple phaco surgery. Lens removed. Cortical matter washed. Multiple IOL given in the bag. Then wash out the visco and the residual cortex. Okay, well placed IOL, then started vitrectomy. It is also a plain and simple case. Just I have to remove the ERM and intend to remove the ILM also. So vitrectomy started. After 4 vitrectomy, I put triamcinolone inside the cavity. But the posterior hyaloid face is quite thick. So I give dye to remove the posterior hyaloid face and ERM first. The posterior hyaloid face removed very easily. Till that time, no problem. Remove the posterior hyaloid face. And now I'm trying to remove the epiretinal membrane. Bit by bit, I am removing. Just when I'm removing this part of epiretinal membrane, see, the complication starts. See, the bleeding start from here. So this is the, sorry, very sorry. This area, the bleeding starts and it increases. I remove the residual ERM as much as possible, increase the IOP, but the bleeding is still there. I tried to just push the clot away from the fovea, remove as much clotted blood as possible. And end the surgery with fluid gas exchange followed by C3F8. And I asked the patient in the table that whether he is taking any anti-platelet medication or something else. Nothing. So after surgery, during discharge, I asked the patient, patient party to go for a platelet count next day. And to my utter surprise, that platelet count 65,000. So 2 weeks before I completed the every test, that time the platelet count was 1,05,000. And the day after the surgery, it is 65,000. It's better in these cases of coagulopathy or blood coagulation disorders. We should do the test as nearest to the surgery date as possible. Thank you.
Thank you, Dr. Mondal, for showcasing your interesting case. Like in your second case, like have you done the laser or cotton?
No, I haven't done any laser. No cotton.
Basically, most of the cases, so if there is a minor,
It's very close to
retinal
that's
trauma.
why.
Yes.
In case of ILM peeling, we have that kind of small little bit hemorrhage which clears within 2 weeks' time. So I thought that after removing that ERM, that it will spontaneously settle down.
That ooze from the capillaries or from the partial retinal tear that may not need any kind of laser or kind of.
Blood pressure was normal at that time. Only thing is problematic is the platelet count. Platelet count is very less.
What is your, like, is there any cutoff value below which you should not go for the
less than 70,000, less than 70,000 we read in physiology book that less than 70,000 chance of is very high. Less than 40,000 is also spontaneous hemorrhage can occur. So it is better if we do any surgery with the platelet count more than 1 lakh. That is a safety profile of platelets.
Do you advise any kind of like platelet transfusion?
Platelet transfusion is required in that patient. After the surgery, patient had 1 or 2 bottles of platelet, concentrated platelet transfusion.
Okay. In some patient with myelodysplastic syndrome or
and patient had fourth cycle of chemotherapy already completed.
Yes. Okay. Dr. Devdulal, any question, please?
Yeah, in fact, the first case was very interesting, and because like we work with assistants and they have their mindset.
Yes.
Sometimes what happens is they do things, like फेको का power बढ़ा दिया, या fluid switch off the fluid. These things happen, and so even without your telling, he switched off the infusion. He or she, and then you had this trouble, and ultimately you are responsible.
Yes.
So really difficult. I mean, like you can't scold them also. Pointless, scolding after something has happened. So, but I keep telling, whenever you do any change or off parameters, please tell and then change.
Yeah.
But the starting point for his first case, I think this case, all the CSSP based video.
Yes.
The starting point of your like series of complication, that is the suprachoroidal infection. Suprachoroidal cannula. So we should be very careful regarding, it is the most basic step, and we are checking it sometimes while pressing the vitreous base. Your cannula is inside the vitreous cavity. You have checked it, but just while releasing it, it may go into the suprachoroidal space.
Yeah.
So that you have to check twice or check it again, or during the surgery. So you should be consciously checking the tip of the infusion cannula. Second thing, what happened that your assistant was suddenly made it at the 0 level, FG, is that's why the sudden retinal incursion doesn't happen first. And the rest of the other things have gone smoothly, and we are fortunate enough that a patient gained 6/9 vision. So thank you.
One more point, Dr. Shubhendu, I want to highlight.
Please,
yeah, when we do base dissection, so sometimes I suddenly found that there is a hypotony because we are so much keen on depressing and doing cutting at the vitreous base. And if we from outside, if we look, the infusion cannula is separated from the trocar.
Mm.
And suddenly when we feel hypotony because we are just pressing and doing the base shaving, this is the very commonly it
Very
happens.
common. It's very common.
Yeah.
This is common in non-sutured era. Basically, previously we used to suture our scadal ports, all
Yes.
infusion ports into the scada in 20 gauge era. So nowadays it is so in those cases, in those days, the infusion canal is absolutely vertical to the scadal plane, and it is tightly sutured. So there is no need of no chance of dislocation of this infusion canal coming out, or there is no tilt also. So it suddenly sometimes bend. Today I am doing one surgery. There is sudden hypotony because the cannula was suddenly pulled aside. So it was there was sudden kinking and there was lack of infusion fluid and sudden hypotony may happen, or sudden dislodgement. These are the things cannula related, all kind of complications may happen. So now I'm coming to my topic. One of our presenter is not here in our session, Dr. Arnav Das, because of some unavoidable circumstances. So we have a lot of time, I think. So my longest RIP surgery, I'm starting my cases. So it was to encounter a humongous intraocular foreign body. It was like a post-traumatic case, clear lens, retrolental written intraocular foreign body, long, slender, separate end. There is a bulbous end, vitreous hemorrhage, and macular detachment. That's when you can see the bulbous end just behind the lens. And it was quite snugly engaged inside that scadal port. So I cleared my vitreous hemorrhage and just extended the scadal port and tried to disengage the foreign body from the scadal side, but that's not coming out. So what needs to be done, because I have to remove such a long foreign body, I took the patient. So I just suddenly remembered the film Atari and the technique. It was kind of lasso technique that to catch the animals. So I used a 60 Prolane, 60 Viking suture, made a noose, and just engaged it around the bulbous end of the foreign body, tightened it, and then kind of lasso technique. I'm just giving pressure, and it is coming out from the scadal port, and fortunate enough to remove this such a long foreign body without touching the lens. So lens was absolutely clear. It remained clear at the end of surgery. And a lot of like retina incarceration was there, fan formation and macular detachment. So I freed all the engaged retina from the incarcerated area, did fluid exchange, laser, and after 1 month, lens was absolutely clear, retina on, vision was 6/18. But after 4 months, there was silicon-induced cataract and the pressure immunosuppression IOL and along with silicon retinal. But finally, patient came a few months back, and at the time his vision was 6/9. At that time, it was 6/12, and it was absolutely on, and you can see the macula is quite healthy, and every scar, all the scars is just outside the vision vascular arcade. So it was kind of very like interesting case, and how I removed the foreign body without touching the lens. But that these kind of hurdles you may face to save the lens, and a series of things you try. So this is another another mode of like your longest days you may face in your professional life. So now, finally, subretinal PFCL, my longest retinal detachment surgery. So retinal detachment cases are always interesting. Anything, anytime, it is such an, like I should say, it is unpredictable case, or in a predictable, in a predictable detachment cases. So, this is a case of I thought it was a total retinal detachment, a bit old, but lot of pigmentary changes, and there was a few breaks were there, not that much. It's tough. I injected typal blue dye to stain the ERM. I regularly used to do it along with the typal translucent dye, and then remove the macular ERM as much as possible. The free the macula, it was quite corrugated and insensible in the PFCL, it was nicely attached. So now I did the all peripheral memory detection, and there was quite tight, looking very sides, it's quite looking tight. Retina is not absolutely freely mobile. So in those situations, I did with this basic session to remove all the residual vitreous and started doing free reduction. Now see what happened. So it was free exchange. Now see there is, I can show you once more. So just see there is migration of subretinal air in the subretinal space. So while doing fluid exchange, so I did a little bit of retinectomy in the infrared area because there are a lot of tautness is there. So taut retina has to be removed, and because sometimes intrinsic retinal contraction can be a problem. So in this situation, so intrinsic retinal contraction was the reason for which there was migration of air inside the subretinal space. So I started doing again fluid exchange, but again the air has gone superiorly also nasally and superiorly. Now I removed the subretinal, I removed the PFCL, but and did a little bit more retinectomy temporally as well as nasally, and again injecting PFCL to settle the retina, and then planning for more retinectomy in the supratemporal area. But somehow the subretinal PFCL has gone subretinally. So I removed the PFCL also. Again, I injected PFCL over the retina. To see one by one, like every complication, it's not going smoothly. So again, I started doing fluid exchange, but still the superior nasal retina was not free and freely mobile, and you can see there is a lot of wrinkling of the retinal folds. You can see. So I removed the PFCL again, and again there was migration of PFCL inside the subretinal space. Again I injected PFCL, and finally I did retinectomy in the supranasal area also. But still some amount of traction is there in the supratemporal area. So finally I did 360-degree relaxing retinectomy. It's kind of 360-degree RR. Now the retina is absolutely free. So it settled nicely. And fluid exchange I completed, and little bit manipulation was required to settle the retina, and laser barrage was done. There was a little bit sagging of the retinal fold. I injected PFCL again, and did laser, completed the 360 barrage laser, and finally silicon on PFCL exchange, injecting silicon with the left hand and removing PFCL with the right hand. And at the end of surgery, I injected sub-silicon oil, triamcinolone acetonide, and you can see that after silicon oil removal also, you can see just after 1 month of surgery, sub-silicon oil triamcinolone acetonide particle, and finally after silicon removal, patient gained this good vision, 6/60, and it is absolutely flat and attached. Little bit of subretinal PFCL is there, but still it is macula is absolutely free of subretinal PFCL bubble. So this is the situation. Sometimes you may think that that detachment is quite, although it is old, not of basically we are very accustomed with the anterior preview, but sometimes anterior and posterior preview, whether subretinal bands are there or not. But there is one condition. This is called intrinsic retinal contraction. This is invisible PR, I should say. It is invisible PVR. So sometimes invisible PVR are really problematic. Nobody of us, we are if you are very much aware of the fact that there is 360 intrinsic retinal contraction is there, you are always in the thought that you should do the 360 relaxing retinectomy. But in other situation, you are not intend to do the 360 relaxing retinectomy. Sometimes you have to do in some unusual situation to get rid of other complications. Thank you.
Beautiful presentation. Always fantastic presentations and lot to learn from you. I have a question.
Yes.
Shubhendu, do you? What is your thought on heavy silicone oil, or what has been your experience?
Heavy silicone, firstly, it is not easily available. It is costly also. It's unnecessary cost burden for our patient. And another thing is, I have injected heavy silicone also, removed it also. But removal is much more difficult than injecting. Heavy silicone oil, it is not basically silicone oil. When you are trying to remove it, it will float up. So it will come to your silicone oil that your tip of the VFC level. But when you are removing heavy silicone oil, it will always drag down. So you have to sometimes you have to use the active suction with the metallic coat needle, and with the high suction you have to remove it over the disc, on the disc, just like PFCL. It is nothing but mixture of PFCL and the silicone oil that makes the silicone oil heavy. So it is around 22,000 per vial, and it's not so easily available in our Indian market. But still, we used to get it from some other sources, but now we are not using it.
I think 5,000 centi-stroke silicone oil helps a lot.
That will for the long term effect. That will, it's not heavy. It's not a heavy silicone oil.
It's not heavy, but it's a long term in such cases will be helpful, because we have done RR.
Have you kept PFCL post-operatively for a short period in any of your cases?
No.
Okay.
There were, but lots of papers are there in a free graft ARG, autonomous retinal graft for the failed macular surgery. They're keeping the PFCL for like 2-3 weeks. Then again, remove the PFCL and injecting silicone oil. These are the one situation where keeping the PFCL in the post-op period. Another thing, in suprachoroidal hemorrhage, expulsive hemorrhage, also they are keeping the PFCL first 2-stage surgery. They're doing vitrectomy, draining the blood, and keeping the PFCL for 2 to 3 weeks. Then again, removing the PFCL and injecting the silicone. This 2-stage surgery, Dr. Stanislaw Rizzo had did this kind of surgery, 2-stage surgery, keeping the PFCL, what you were telling, in the post-op period. But I have never done it.
I have one question. For relaxing retinotomy, which one is better, in fluid-filled cavity doing relaxing retinotomy or gas-filled cavity?
It's always better to do in the fluid-filled cavity, because you will. What is the reason? Because you have to allow the retina to bleed. Otherwise, you may face the problem if you are not facing it intraoperatively. During the fluid exchange, there is some kind of tamponade, and due to surface tension effect, the blood may not appear. But post-operatively, you will see there is a lot of high fever because patient is maintaining the prone position. But in the case of fluid-filled cavity, if you are allowing the blood to come out, so that you can do the cautery and you can stop the bleeding intraoperatively. Otherwise, during fluid exchange, due to pressure or due to surface tension effect of the air, the bleeding may not happen, but it may happen under the silicone oil, and that is much more dangerous than that may come out anteriorly in the anterior segment, and even like corneal blood staining can happen. Then everything is gone out of your head. You have to be under the
case. Isn't it easier for you in this case? There is one a detached retina, you can say under FG, fluid gas exchange. So if you did that retinotomy in the fluid gas exchange state, then at that time, you don't have to again start fluid and again remove it, again give PFCL. So you have to do it multiple times. If you did that under fluid gas exchange, the detached retina, if you relax that portion of the retina by doing retinotomy, it will be much easier for you in this case.
Now, if you are sure that this small retinotomy is good enough to settle this retina, not much of traction, or there is any time constant, because you have a lot of cases you have to do, so you are a little bit in hurry situation. That in those situations you can do it, but still, if you are doing it nicely and completely, and like in a cool, calmer way, but in a relaxed way, start the infusion, and then judge your mobility of the retina, how much mobile it is. More mobile means more chance of uh, smooth settlement. If it is less mobile, that means some kind of intrinsic retinal attraction is there, so the retina may not settle. So you have to judge your retinal mobility, how much mobile it is.
Another thing is doing long retinotomy, large retinotomy. After that, we usually put a bit of triamcinolone. If the triamcinolone in subretinal space, that time, should we use subretinal?
There is no need to remove it. There's a lot of study has been done, animal study and as well as human study. They are telling that is have toxic effect of the photoreceptor, but in the long run, that doesn't have any effect on the molar cells or the photoreceptor.
Okay. Thank you. Good presentation.
Nice video.
I have one thought,
Yes.
actually, not really a
Please,
question.
please.
So for the first case, you did a wonderful lasso technique of pulling out the intraocular foreign body. So I think like what is very important for people watching is that retinal surgery or VR surgery, for that matter, is not a 1, 2, 3, 4 game. It's like one could be followed by 10 even, or maybe 31. So like
Yes.
you have to think out of the box.
Out of the box.
Very unpredictable, and I mean, this is where actually the common sense part of surgery comes in. So and
Yes.
so a very, very nice innovation, if I may call it that way, because this is a huge foreign body. You could not have grasped it with any intraocular forceps easily, at least, and then taking it out, getting the force to take it out would have been really difficult. So really wonderful.
Normal lens, preserving the normal.
Absolutely.
Yes.
Absolutely.
With such a long foreign body.
Absolutely.
More than 20 millimeter.
Yeah.
Mm.
It's
Regarding you talked about silicon, I mean, like triamcinolone acetonide, on the borders of the retinotomy, but do you use it in PDR cases where there is combined RD or
Yes.
lot of
Basically, PDR cases or diabetic DME cases where we are doing the vitrectomy with ILMPD, in those cases also under FG, I'm keeping the small 1 or 2 drops of wound, I say 2 drops of triamcinolone
that will
particles over the macula or
macular edema also.
Macular edema also in PDR cases, that will control the little bit of blood ooze or kind of macular edema, whatever is there. You have done the membrane dissection bimanual surgery for the combined retinal detachment, but there is no macular edema. You have not done the ILMPD, but in at the end of surgery under the silicone oil, you can just, after doing fluid exchange, you just put 2-3 drops of triamcinolone and inject the silicone. That will control the PVR, control the blood ooze. Even it can control the disc ooze also. The triamcinolone particles can block the capillary openings, and that can stop the bleeding also.
All the inflammatory processes actually.
Yes, all the, because diabetes are the chronic inflammatory disorder. So it's nice discussion. I think. Thank you all the speakers for your showcasing your all the beautiful cases. Thank you, Dr. Dharmesh. Thank you, Dr. Devdulal. Thank you, Dr. Shantanu Mondol, Dr. Aditya Kelkar, and Dr. Nido Maiti. So we do you have any time for? Hello.
Yes, doctor.
Do you have any redundant time?
So actually the session is till 3:55 p.m. So if you have any kind of more discussions to go, then you can go ahead.
So any other cases are left? Like Dr. Devdulal, you want to showcase any more case? Anything?
Actually, I will just check if there's anything in this laptop.
Dr. Dharmesh?
Yeah.
I have one small video of endophthalmitis with foreign body.
Yes.
We'll just share you the video. Nothing great, but yes,
But still,
I'll share it.
we should utilize our extra time. Dr. Shantanu, any other video is there?
It's uncut.
I've got one video. I'll just, can you see it?
Yes.
Yeah, it's just bad endophthalmitis. It's a traumatic endophthalmitis with foreign body. So it's a very, usually the trauma cases are very challenging. The membranes are so bad that to making out the membrane or raise the retina was so difficult. And the foreign body was so large. So after clearing everything, then we found the foreign bodies. And so what we did is we just enlarged our used ILM forceps, or the ILM forceps which was not very sharp. And we have used that forceps to just grasp the foreign body. So even just wanted to show that, it's always a difficult case in the beginning because it's so much of membranes and all in the traumatic end of. And old ILM forceps can be used as to hold the IOFB things.
Nice case. I was just wondering, any of you using magnets for IOFBs, iron IOFBs?
Yeah, we have used in the.
Okay.
It's hold pretty well. Only thing it's to be, the port should be quite large enough to take it out. Otherwise, it just drop it back from the, when we exactly have some resistance, it drop it back.
Absolutely. That's that's one problem with magnets.
Yeah, so it's hold it very bad. It helps a lot to lifting up from the retinal surface.
Yeah.
Or otherwise, we can use some other forceps to grasp after we lift from the retinal surface.
Absolutely, because some of these are so big, really difficult to actually find any forceps to hold them properly. So magnets, once in a while, they are really helpful. But of course, if you have a glass foreign body or something of that sort, then you are in soup.
Yeah, it's the most tough part to have a glass foreign bodies.
Right, absolutely.
And every time it drops back, it cuts the retinal surface. So. You are mute, Dr. Debdulal. Dr. Borel, you are mute. Can you unmute yourself? Dr. Borel. Yeah, Dr. Borel.
Yes. Thank you, Dr. Dharmesh, for nice surgery. Dr. Devdulal, any other case?
In that surgery,
Yes,
that
opening up one.
ILM forceps. Why didn't we hand use that? That is really good. I appreciate.
Don't throw away your ILM forceps.
I'll just show one case as we have time.
Yes.
So actually, just a moment, I'm trying to open it up. So regarding macular holes, actually, so actually it's slightly different technique that I have been using for a while, and this is something that we actually have been able to kind of present elsewhere and publish also. I hope my slides are visible, and is it visible?
Yeah.
Yes, visible.
Okay, so this has been presented elsewhere. So many a times we are left with, a recurrent macular hole, a very large macular hole, which is so common in our country. So this is mobilization of the retina, which can be done with a silicon tipped cannula, and actually, you can remove the fluid from the macular hole, just like as you do in a retinotomy. So nothing to be scared. This is a patient who underwent a macular hole surgery elsewhere, and there's a large, nice ILM peeling that the previous surgeon has done. But unfortunately, the macular hole has opened up. So this is a soft tip cannula that I'm using to just massage the retina from around the macular hole, and then fluid air exchange, and then drain out the fluid from the macular hole. Believe me, this I have done in more than 100 cases now, and this really works, and we've published this also, and this really works, and is a helpful procedure where there's a recurrent macular hole. Otherwise you will have to do a graft of the retina, like some of the authors have published and shown. So this is an easy technique, everybody can do it, and we have a silicon tip cannula with all of us, and we can just do a massage. And the small petechial hemorrhages that happen on the retina, these actually go away, just like with fluid air exchange. And we've also done 10-2 following this, and the retina functions properly. Most importantly, the ESA DLM, it comes back. It comes back faster. It also comes back following inverted flap technique. But this is a direct closure of the macular hole on the table, and it really works well in a lot of cases. So this is something that I've found really useful in a lot of large macular holes, 1000 plus macular holes.
So one question: what at the end, what gas you are using in these cases? Unmute yourself. Please unmute.
Yes, large macular holes, I always go for C3F8. Why? I'll tell you. Because if a patient is compliant and positions himself or herself in a prone position, is there for 2-3 days, then the macular hole is going to close. But in our situation, most of the times the patient will be sitting straight, or maybe even sleeping supine. So what happens then is, unless you have a C3F8 filled eye, full gas, and the macular hole opening is actually blocked by the gas, the fluid is again going to go back. And there's a very nice review that has come up regarding macular holes, and it says that if you have fluid touching the edges of the macular hole, that's when the macular hole actually comes back, and recurrence occurs. So you have to block the fluid, especially in these large macular holes, from going inside the macular hole or touching the edges of the macular hole, if you have to close this. So for me, large macular holes, recurrent macular holes, only C3F8. And I ensure that I do an exchange. I don't previously I used to just inject 0.3, 0.4 just to keep the pressure going, but now it's a 15-18%, 15 to 18% C3F8 exchange that I do, and this really has worked wonders. Very few recurrences that I have had over the last 2.5 years. So maybe less than 1% recurrence. So that is something that has really helped.
Okay.
I have just one point to make is I use sometimes 40 gauge cannulas. So it's a small macular hole. No, the silicon tip bore is quite large. So I use the 40 number cannula to just aspirate last tip of fluid from the macular hole. And it, as you suggested very nicely and shown correctly, that it's on table closure. So immediately it closes down there.
Yes, I think macular holes so far have been kind of no touch area for the you cannot drain, because our teachers used to tell us you cannot drain a macular hole, but it's to the contrary. The fluid is really viscous. If you drain it with the silicon tip cannula, you'll obviously with the 41 gauge cannula, it's a smaller bore, so maybe the viscous quality will not be able to comprehend. But with the silicon tip cannula, it's a viscous kind of a fluid that comes out from the macular hole. So if that is there, then there's no way the macular hole is going to close. And I think in the time to come, this inverted peeling technique and all need not be done, because you can straight away drain a macular hole and close it on table. So that is something that I firmly believe. And even in small macular holes, you don't actually, even a ILM peeling is good enough, because the traction is gone and it's going to go. What a ILM flap actually does is it provides a scaffold for the tissue to grow. But here you are opposing the tissues, and it's almost like, you know, healing by primary intention. So that's the difference between you know, a scaffold allowing the, you know, cells to grow and then close the hole, and this where there is a healing almost by primary intention. So this is something that may be tried.
Is there any prospective studies regarding this spontaneous closure with the massaging and vis-a-vis ILM inverse flap? Is there
There is
any
no prospective study with massaging. Probably ours is the first kind of large series, 41 cases we've published with massaging. There are two other reports that have been published. These are recurrent holes. One is actually with a DDMS. They have induced a retinal detachment, and then they have massaged, and then they have drained the fluid. So you do not need to induce a retinal detachment. Retina is quite flexible, quite mobile. You can just massage it. And you know, regarding this silicon tip cannula, it is less traumatic than the DDMS. That's one. And the other case that has been reported in a journal is again a recurrence of a hole where they have you know, drained the fluid from the macular hole. So these are the two case reports. So ours is a retrospective study of 41 eyes that have been done, and so it was published in IGO this April. And in fact, from you know, subsequently I have come to know from many other people from across the country, and a couple of two beyond that, they are also using this you know, retinal massage. So I think in time to come we will have more publications regarding retinal massage for macular holes.
So, Dr. Shantanu, anything?
No, I don't have anything.
I was searching my
Database.
this one, like
Do you have any of your RP flaps video?
Or subretinal fluid removing.
subretinal bit. Basically, we have some time. I think like 10 minutes is there.
It's 45, 10 minutes we have.
Mm-hmm. Let's see whether.
Very good.
This is quite interesting. Sharing my case. This is directly from the like my. Can you see my timeline?
Yeah.
This is going to be published in Retina, coming Retina. That is role of small gauge proportional reflux assisted hydrodissection in elevated symptomatic vitreofoveal traction. So this is vitreofoveal traction can sometimes be so much that may lead to macular hole formation. So used an innovative technique of just make an opening in the posterior highlight phase, then using proportional reflux hydrodissection. This animation I made so myself, so that highlight phase may be separated from the and the traction will go. And this elevation I have seen the maximum highlight retina distance from nasal and temporal area where it is maximum. So this is temporal, superior, inferior, nasal, this 4 quadrant. I have just used it, and just here coming to the live situation where it is a case of VMT, and a lot of success changes I have seen. The measure this is highlight retina distance, and I have did the vitrectomy and stained the posterior highlight membrane, made an opening here in the that quadrant where the highlight phase is maximally elevated, and using proportional reflux going beneath the posterior highlight phase, and just with this hydrojet, it is releasing the posterior highlight from the elevated fovea. You can see the associated air also helps to displace the highlight phase from the elevated fovea safely. This is one of the safest technique. There are basically a lot of other methods of removing this PVD induction in cases of elevated highlight vitreofoveal traction, because these are very delicate cases. You may land up in intraoperative macular hole formation. So in this case, I've used this technique to remove the highlight phase safely in my technique. Like so, postoperative macula is absolutely flat. This is another case where after doing vitrectomy, you can see the taut highlight phase nicely, and I stained the vitreous residual vitreous with the transition acetonide, and now the highlight phase is absolutely visible. I just made an opening here. You can see the opening, and now I'm engaging my cutter. This is small gauge cutter. I named it small gauge proportional difference SGPR. That is either with the 27 gauge or gauge or 25 gauge vitrectomy cutter, not 23 gauge. And just lifting up a little bit, enlarging it, and just insulating my cutter in between the highlight phase and the retina. And just now I am using proportional reflex. You can see the fluid wave which is going out from the cutter tip, and sometimes air will come out. In my first case, it was nicely detached the highlight phase from the elevated fovea, and you can see the fovea is quite elevated. It's very much boggy, and finally I separated it nicely. Retinal touch may happen, like in this case, a small blanching here, but it will go off postoperatively within 2 weeks. And the surrounding retina is also very much tightly adhered to the underlying retina. And I removed the highlight phase so beautifully and safely, I should say safely, and do the vitrectomy in that case. Another case where you can see the glistening reflex from the posterior highlight, and I injected tyrosine acetonide because it is the best dye to stain the residual vitreous and the highlight phase. And made an opening here because the maximum highlight retinal distance was at the temporal quadrant. You have to measure it on the OCT. And insulating my cutter here, now I am just, it is PR is on, and I'm just, it is basically separated. The highlight phase is separated from the elevated fovea, and you can just lift it up single go. So this is quite safe technique. This is ahead of print the coming Retina journal. It's one of my achievements. Like you should say, like Retina publishing in Retina is quite difficult, and as a surgical technique.
Congratulations.
Thank you.
It's excellent technique.
What is the
Another
pressure
case.
you use?
Pressure, the maximum you can go up to the 100 level on the 70.
Okay.
Here. That I made the opening here in the nasal area because the nasally it was much elevated. Now I'm using proportional reflex. You can see that this impending macular hole here. I can see the jet of fluid is coming out. Rest of the thing, it is separated. Basically, intraoperative OCT, we don't have this kind of facility here in our hospital, so I couldn't have done the intraoperative OCT. It would be very good to take the
document perfectly.
But it's not done. But you can see to do it in the high magnification. So this might this kind of elevated fovea that its impending macular hole is there. I can just retina is becoming absolutely flat in this situation also, in other case also.
one question I have. This is removal of ILM or along with ILM peeling. Along with ILM peeling, removal of this.
You may or may not do the ILM peeling. If you do the ILM peeling, you have to. It has to be the phobia sparing ILM peeling. Otherwise, you can land up in problem with macular hole.
Phobia sparing, but do you do only this technique to the VMT cases, or along with that you remove the ILM also?
Not in all cases, but only that is the purpose of this technique was to showcase how you are separating the traction. You may or may not do the ILM peeling. In one of my cases, I did the ILM peeling. In other cases, also I did ILM peeling, but not in all cases.
Okay. Okay. Is there any chance of recurrences?
Recurrence of ERM, it is less if you do the ILM peeling.
We use this procedure in the diabetic TRDs.
Yes.
Yeah.
If the phobia is much elevated and if there is impending macular hole formation, you may use this kind of technique.
Okay.
Yeah. So the use of proportional reflux hydrodissection, it is not described in VMT. So vitreofoveal traction. So this is
mainly used for the diabetic cases.
Yeah.
Diabetic cases we are used to do the proportional reflux for a long time, but not.
All due respect, sorry to interrupt, but I would request all the doctors that within 1 minute our session is going to end.
Okay, Dr. Maiti, you want to showcase any case?
So we have only 1 minute to go.
Yes.
Time is over.
Yeah, exactly.
Okay, thank you very much.
So thank you for rejoining us to us live. Thank you.
Thank you so much,
you to the all
our chairperson, Dr.
speaker.
Gopal. Thank you so much
Yes.
for sharing the session and all the renowned doctors for such an informative session. Thank you so much and have a nice day.
Thank you.
Thank
Thank
you.
you for the nice discussion. Hope to see you in the next AIOC.
Thank you so much. Thanks for this.
Thank you.
Same,
great
Bye. Take
same
care.
I
Thank you
see.
so much.
Bye.
Bye.